I will take you through this case, a typical kind of patient who you will see during your pediatric appointments. If you don't understand everything now, as you go through your clinical appointments, you will understand these things. And I think Professor Chamari from pharmacology will be uploading hers as a presentation on LMS, and then Dr. Priyani will also be doing her presentation most probably after her pathology lecture on pneumonia, right? Right. So I'm talking about an 18-month-old girl who presented with high-grade fever with tricos. But you all know what tricos are? Do you know what tricos are?
Yes, madam.
Right. So that is, yeah, that's a kind of shivering which comes with chills and rigors. So an 18-month-old baby is too young to say that she is feeling cold. But you can appreciate the rigor if she's having one. So fever with chills and rigors is typically associated with a pneumonia. There can be other causes like a UTI or even sometimes with viral fever, right? So she also had an associated cough which didn't have a diurnal variation, meaning that it was present throughout the day and there was no special time of the day. She also had difficulty in breathing associated with this cough. And she wasn't her usual self. She was not eating properly and she was off feeds. So this was the history that the mother gave you, and as the doctor, when you examined her, she appeared ill and she had a very high fever of 103 Fahrenheit. So she was dyspneic, meaning she had difficult cyanosis. The respiratory rate was increased and it was 45 breaths per minute. Now, there were intercostal, which means in between the ribs, and subcostal, meaning below the last rib, right? Recession. So, indrawing of the chest, once again depicting difficulty in breathing. And almost any hospital now has saturation monitors. And when you check her saturation, meaning the level of oxygenation, it was slightly on the lower side with 92% in air. Usually you expect a child to have 95% or more of saturation in air, meaning without oxygen. On further examination of the respiratory system, there was impaired dullness on percussion over the right lower zone. And when you auscultated with the stethoscope, air entry was also reduced in the same area. And you heard bronchial breathing over the right lower zone, right? So when you auscultate with the stethoscope, usually what you hear is vesicular breathing. And if a child is having asthma, you can also hear additional sounds like bronchi and crepitations. These can also be present in a lower respiratory tract infection. A child with pneumonia can have bronchial breathing, right? So you will learn all these things during your clinical appointment, right? So usually when you percuss, the percussion note is resonant. So if there is dullness, that means that there is a patch of consolidation depicting a pneumonia. right? So with the presence of bronchial breathing, reduced air entry, dullness of the percussion note, you have diagnosed a right lower lobe pneumonia in your patient. Now, once you have detected this, you have to start management. So because the saturation is 92, you have started the patient on face mask oxygen, 2 liters per minute. You can also use nasal prong oxygen, and the saturation with that has gone above 95%. Knowing that this child needs IV antibiotics, you have inserted the intravenous cannula. And while the cannula is being inserted, you have checked the full blood count, CRP, and also sent blood for a culture and antibiotic sensitivity. Because the child was off feeds, you check a capillary blood sugar, which is normal. So in addition to the blood test, you do a chest x-ray and you start the patient on IV benzyl penicillin because you are suspecting a lobar pneumonia. And the most likely pathogen here will be something like a streptococcus pneumonia. Can you see this chest x-ray, which shows that there is right lower lobe pneumonia? So when you get the results back of the full blood count, as expected, there is a neutrophil leukocytosis. The C-reactive protein is very high with a value of 219.8. And the blood culture comes after 24 hours and it shows no growth. Usually in a pneumonia, you will not be really isolating an organism, but we still do it. Now, in spite of having started intravenous antibiotics, the fever continued to spike in this child. And there was no improvement in the clinical condition also. So thinking of resistance to benzyl penicillin, the antibiotic was changed to third generation cephalosporins after 48 hours. And cefotaxime was given intravenous. But in spite of having changed intravenous antibiotics, the fever spikes continued. And the respiratory distress, the difficulty in breathing started worsening. The clinical signs also deteriorated, very markedly reduced on the right side, and the percussion note, which was dull earlier, has now turned to stony dull. The child has now developed a complication of the pneumonia, which is a pleural effusion. And the chest x-ray was repeated. Right, so here, this is a typical chest x-ray which shows a pleural effusion. So when you have a pleural effusion as large as this, it is not going to settle with intravenous antibiotics. A pleural aspiration and insertion of an intercostal tube was done. And this child ended up needing surgery, a thoracotomy with evacuation of this end-pipe. Right? So only once this was done, the fever settled. Right. So now this is the kind of a complicated pneumonia patient that you will come across on and off. when you do your pediatric appointments at Lidge Bay Hospital, right? So I have just gone through how you would clinically assess this patient and start off the initial management. Further investigations and treatment will be discussed by both Prof. Shamari and Dr. Priyani from pharmacology and pathology, right? And you will be able to add on more knowledge as you go through your 3 clinical appointments in pediatrics as well as your professorial appointment. Do you all have any questions to ask me? Right. So I will be sending this presentation to Dr. Hasita Lianarachi and ask him to upload on the LMS so that those who have not been able to join as well as you all will have this. Okay? Right. All right. Thank you then.
Thank you, madam.